Welcome to Full Face Orthodontics. I'm Dr. Derek Mahoney. I'm a specialist orthodontist from Sydney, Australia. My philosophy in orthodontics is very much about early treatment and minimizing the extraction of teeth, so we end up with better airway and better looking faces. And so what I'd like to discuss with you is how this philosophy is developed and what impact this would have for your child. When I graduated from orthodontic school, we were just taught how to straighten teeth. And we were taught that the ideal age to start orthodontic care would be in the dentition when all the permanent teeth had erupted. So for most children that's 12, maybe 13. But what I've learnt over the years is that the face finishes growth much earlier than 12 and 13. So if I'm going to try and influence facial balance, I've got to get in much earlier. So many patients are referred to me by their dentist for a problem associated with their jaw. And the dentist tells the parent, your child's upper jaw or palate is narrow. So I want you to see this orthodontist because he believes in early treatment and he'll be able to do something to help your child's upper jaw develop to the size it should be. So let me explain that in more detailed terms. If you were to look at a skull and look at the upper jaw, the palate is in fact the floor of the nose. So the majority of patients who have a narrow palate have that narrow palate not because of genetics. The theory of mum has a small jaw, dad has big teeth, that's why young Johnny has crowding, has no scientific merit. Where the research is aimed is talking about the relationship of the nasal breathing to the development of the palate. So if something here is preventing normal nasal breathing, for a child it could be nasal valve collapse, it could be large turbinates, which affects their breathing because of nasal allergies. It could be large adenoids or tonsils. Anything that affects nasal breathing will directly have an effect on the growth of this jaw. So in my practice, many patients come to me with a thought of, why am I here? My sister took her child to an orthodontist and was told the best age is 13 because that's when we can do the braces. Why is it that my dentist has sent me to you and my child's only 7? And then I need to explain to that parent, because between 7 and 9 we get maximum growth of this jaw. So if something's impeding that growth, that's when I want to intercede. And by doing what I do, your child may not need as much extensive orthodontic care later in life. So what do I do that's different? Well, rather than just look at the dental crowding, I look at the child's airway. I work with respiratory physicians, I work with nose and throat doctors, I talk about the child's sleep. For instance, I have a lot of children referred to me who have attention deficit disorder. And for many years, ADHD was thought to be a neurological condition, and yes, there are cases like that, but the majority of children who have ADHD actually have poor sleep. Adults who do not sleep well at night, they become very lethargic during the day. Children who don't sleep well at night tend to become hyperactive. But the cause of the hyperactivity is really related to their airway and their sleep cycle at night. So I ask parents to take a little video of their child while they're sleeping so that I can hear if there's snoring, so that I can see if the child sleeps with the mouth open, etc., etc. Many children who wet their bed at night, right? That's related also to narrow palate, to a poor nasal airway. Adults who have the similar problem, they get up and they go to the toilet 1 or 2 nights every sleep cycle. And that's not normal. And one of the questions respiratory physicians ask their adult patients, they ask them about nocturia. In other words, how often per night do you have to get up and go to the toilet? The correct answer should be 0. But if the answer is 1 or 2, that's an early sign of sleep apnea. In children, rather than get up and go to the toilet, they wet the bed. So again, the treatment of that is focused on the airway. So what I do in my practice, I examine the kid's airway, I look at their sleep cycle, and then I link that to what I see in the development of the jaws, the dental crowding, etc. So the traditional approach, wait till 13. If there's no room for the teeth, pull some adult teeth out, put braces on. My approach, don't wait till 13. I want to see the patients by age 7. And the American Association of Orthodontists agrees with this. On their website, they have a great section for parents to explain why 7 is the best age to seek the first consultation with an orthodontist. Because at 7, you can look at the development of the teeth. You can still have time to change the facial development. You can assess the child's airway, etc., etc. And most of my patients, once they see what I've done for their children, then tell all their friends that no, don't listen to your dentist if he's telling you that you can't see an orthodontist till your child has lost all their baby teeth. Listen to what Mahoney has to say. Take your child early. And that's not to say that we treat every child at that age. Many children come in at 7, I look at their palate, it's normal size, they have a good posture, their tongue's in the right position, so we then tell them there's no need for intervention. But then at the same time, the child that comes in who's a mouth breather, in the old days this was known as adenoidal face, the sort of open mouth posture, and they sleep like this. What is happening to that child? That child is not getting the functional stimulus to their jaws to allow normal facial growth to occur. That's the child that needs early intervention. What is that intervention? It varies from child to child. Some children just see nose and throat work. Other children, we use devices such as these. These are called expanders. What these do is they make the jaw the correct size for the eruption of the teeth. And by doing this expansion on a slower basis, remember, this affects that. So by doing the slow expansion, we also improve the child's nasal breathing, which improves their sleep cycle. Children grow during sleep. Growth hormones are released during stage 3 non-rapid eye movement sleep, which is a technical term for deep sleep. That's the refreshing sleep. Children who cannot get to that stage of sleep or only stay in that stage for a small period of time tend to be the children who are the mouth breathers. The other common aspect, many times I get a patient ask me, Dr. Mahoney, I have a young child who grinds their teeth all night. What is that about? In the past we thought grinding was related to stress. And it is in many patients, particularly adults. But for children, grinding, for the majority of patients, grinding is known in our profession as bruxism. And the majority of children who brux their teeth, young children, it's because of airway obstruction. There's been research to show that if a child has large adenoids and tonsils, brux their teeth, if the adenoids and tonsils are removed, there's a 70% chance of the grinding stopping. And that's very, very good research. So again, the questions I ask my parents, who bring their children, does your child wet their bed at night? Does your child snore? Does your child grind their teeth? Does your child sleep with the mouth open? These are sort of non-orthodontic questions, but important questions for me to piece the puzzle together to make sure I give the appropriate diagnosis and institute the appropriate care at the appropriate time. And I think that's what separates what we do at Full Face Orthodontics compared to the traditional model. Well, thank you very much for joining me, and I hope you got some benefit from the new information I've had to present. If you'd like further information or to contact me directly, feel free to visit my practice website, which is www.fullfaceorthodontics.com, or you can email me at info@derekmahoney.com.